The International Society of Heart and Lung Transplantation is initiating a process to record interviews with pioneers in the field, both the evolving field of heart and lung transplantation as well as the parallel evolution of the society itself. It's my very great honor to be here today with you, Professor Cabrol, as you've had a seminal impact on the development of this field as well as a very important role in the society. I wonder if we could start by talking a little bit about your early education. In particular, what sparked your interest in medicine? You were a Fulbright scholar, I understand, in the 1950s, and what led you down the pathway toward a career in medicine?
Well, I was born in a farm, in a small village, and no other ambition than to be a general practitioner like my grandfather. But he says, no, you must be a surgeon. So I went in Paris and the School of Medicine, and I did for that. And I had my first chief in surgery was also professor of anatomy. And he asked me if I will be a professor of anatomy in 4 years, because there will be a vacant place. Oh, well, maybe. So he asked me to do a work on lung anatomy. And he says it would be a small thing, but we worked 4 years about that. And I think that's the best book of lung anatomy I know. But nobody speaks about that. Anyway, then I was professor of anatomy, and he said, but you're a surgeon too. Yes. So what kind of surgery are you doing? I say, like you, sir, gynecology, that's all right, small operation night. He said, no, you're doing lung surgery. So I did lung surgery, and during my stay in the thoracic department, my boss said, well, the lung surgery is just tuberculosis now, and they will find an antibiotic, so we must learn cardiac surgery. So I just read there was an American, he's entering into the heart. You must go there. I will find you some money for that. So I was Fulbright fellow, and I went to see this famous surgeon that was Walton Lehi in Minneapolis, Minnesota. Mm-hmm. And I spent 1 year there. And it was absolutely fantastic, fantastic. I said to James Kirkland, the Saturday we will back to the Mayo Clinic and see John Kirkland doing open heart operation also. But in Minneapolis, that was very, very simple, because we use some pump for cows, milk pump for cows, and also with a hose from the garden to do the oxygenator. So that was absolutely fantastic, and I was enthusiastic. So I went back to Paris, and but my boss was accepted a post of director of the general surgery clinic in Geneva, Switzerland. So I understood the humoristic principle of Shumway when he said, the most difficult thing in cardiac surgery is to getting the chance to do it. But fortunately, my professor of anatomy had a big department of general surgery, and he said, "What you are doing cardiac surgery there?" And there was no private room, no electronic equipment like we had available in the States. So we start in such conditions, and each time, because there I met two friends in Minneapolis. One was Norman Shumway, and he went back to Stanford. He had some problem also, but finally he did open heart surgery there. And with the first resident, Richard Lower, they experiment on the way to, because if really I entered the heart, you don't arrest it.
Right.
So they are doing on dogs some experiment in order to stop the heart. They interrupt the coronary circulation, then they put cold saline, so the temperature of the heart was done. It was the well-known technique of local cardiac hypothermia. But doing an experiment, Laura tried to use the inactive hour of wetting during the hypothermia, and they resect the heart and they put it in place. And finally, the dog was looking fine after the operation. So Richard Loward said, "Oh, wonderful! We have succeeded. Heart transplantation." No, said Shumway, no, it's not it is an autograft, not an allograft. So the next experiment, Lower take the heart of another dog and he implant in his operated animal, and this animal survived. And Shumway says, somebody in the media knows about these transplanted drugs, and there was a lot of inquiries on the head of the department, and this one was exasperated, and he asked Glover to kill the animal. And Shumway said, well, either the dog and the chairman lasted too much, so some kind of poetic justice was achieved. And anyway, during that time, though, so I come back to Paris, and each time I have the possibility to go to the States for a surgical meeting, I visit Shumway. So I saw his experiment on heart transplantation, and he said, "Chris, you must do it. Someday that will work." And finally, I have an assistant, Gerard Giraudon, and together we trained, practice experimental cardiac transplantations.
So this would have been in the mid-60s,
I was a professor of anatomy, so I have a small laboratory, experimental laboratory, so we can do those experiments there. But my second friend in Minneapolis was a South African surgeon. He went back to South Africa after his training there, and we don't have any news about him, except that 10 years later he was sent to Richmond, Virginia, to learn from David Hume renal transplant. So there he met Richard Lower, who were there after his training in Stanford, and he was doing their open heart surgery, and also he continued his experiment on the cardiac transplantation. So our young South African surgeon was highly surprised to see the success of the experiments of Richard Lower. And he asked why Dick has not done any human heart transplantation. And Dick said, because here the procurement of a heart from a brain dead patient donor is not yet acceptable. So I'm waiting for favorable circumstances. But a young South African surgeon was not much embarrassed by that. He went back to Cape Town, did some experiments, several weeks only, and never had any dogs living. But December 3, 1968, he took the heart of a woman killed in an accident and transplanted in a man with Bachansky. And he succeeded. the next day, the whole world understanding name, knew his name, Chris Barnard.
Yeah, with so little experimental experience in his own laboratory, And yet it was a success.
Yes, because I think he learned the technique from Lauer, and I think Chris was a very intelligent man, and he was also very tenacious, and so he decided to say, "I will be the first," and he was the first. Anyway, others followed, and Kantrovitz, and then Barnard did the second one, and also who did Kantrovitz also, then Shumway, and then Singh in India, but in Europe nothing. In Europe nothing.
There were difficult days, very difficult years, the time between 1967, 68, and the eventual beginnings of success in the field in the late 1970s. Can you tell us a bit about what was happening in France at that time?
The Barnard's tour in France was not so good, and the French cardiologists were not ready to do it. And the most famous of them, Professor Lenègre, said, "Is not to start heart transplantation now is premature," he said. So nobody tried, but we were trained with Gérard Guiraudon and ready to do it. So we have three favorable circumstances. First, we had in the hospital the head of cardiology department, Professor Faquet, a man we don't believe in anything, but encourage everything. And he accepted to refer to us some patients. But really, they lived only a few days, and we never had the possibility to have a compatible donor, except that this day, April 27, one survivor. C'était Monsieur Clovis Roblin, 60 years old, dyspneic, tachycardic, cardiac output 1 liter, 1.2, terrible. And but he was still living, and he accepted immediately to be transplanted. He said, "I cannot go further." Finally, second circumstances were 3 days earlier in the emergency neurology department. Was a man dead of a car accident in brain death, certified by electroencephalogram basis, and he was no contraindication, and the family accepted the donation. And the third circumstances, I was not the chief of the small unit, but not of the department of general surgery. And this day, our head was not there. He was in Algeria for a meeting. and then he never allowed such adventurous attempt, certainly not. But I asked Gérard Guiraudon, my assistant, to call him, and he said that. He admitted that some days later. You know, Bas, because we know where he was, it was easy for me not to find him.
Sometimes the circumstances are perfect then.
But it remained for me to see Mr. Roblin, and but during the long walk to the cardiology department, which was located at the other end of the hospital, suddenly I realized the importance of that things and its risks. But when I saw Mr. Roblin, he brought me to the essential. He said, "That's it, all right, I'm worn out." So after that, everything was like we planned, and we did this operation. The heart of Mr. Roblin was very big, weekly beating. But when I operated on the donor, I found a small heart, because the normal heart is very small, but very vigorous. And I check it, I excise it, and then we transplant this small heart. And when all anastomosis were done, and he was in place in the huge cavity left by the dilated heart of Mr. Roblin, who were surprised, can this small heart could make it. And he was fibrillating at that time. We take the 2 plates of the defibrillators, and for a shock, the heart stopped. Long seconds. Then one beat, another one. Oh, wonderful. And the electrocardiogram was absolutely normal.
And what were your thoughts as that was happening?
and so that was very, very nice. And even we see some signs of awakening, Mr. Roblin awakening. Unbelievable. Everybody remained silent in the operating room. And just my friend and immunologist, Léon Schwarzenberg, whispered, "He's straight."
What a momentous moment that must have been.
It was a very nice time. So we finished the operation, and we was ready to close the sternotomy. Then suddenly the arterial pressure dropped, and the heart distended, and the vasopressor drugs were inefficient, and we have to do a direct massage of the heart. Fortunately, I was with my wife, Annick, who was the anesthesiologist in our unit, and I think I never see so wonderful anesthesiologist. She was with me in the States, and when I was in the States, they don't ask me to stay, but they ask her to stay. Well, finally, after 40 minutes of resuscitation, the pressure went up, and finally we can close the sternotomy, and we put Mr. Roblin in a separate room nearby. But we were discreet. But the day after that, the media knows, and the transplant, and the newspaper said the thing. So, and that day, my boss come back from Algeria. Somebody immediately asked Gerard and me in his office, and he was very furious, and that was that was tough. And finally, at the same moment, the phone rang, and it was the head director of all the public hospitals in Paris, asking us to be immediately in his office. So we went there, and there was another tough dispute there. But Gérard Guiraudon, just to comfort me, said, "Boss, you're lucky. They don't handcuff us."
But as your patient continued to do well.
So, and the director said to our head, "You must give press conference." So we have to give press conference with microphones, etc., etc. The situation was a little better, but without any Mr. Roblin don't regain consciousness, and but the blood pressure was pretty good, and but following day, the situation was deteriorated, and we don't succeed to save Mr. Roblin, and he died Thursday. At the autopsy, we knew the cause of death. It was a massive pulmonary embolism. We don't pay any attention to that because Mr. Roblin was bedridden for weeks, and he had a lot of clots in the legs. And when the donor heart was vigorous, he pushed the clots there. So that was a failure.
Well, but the field moved slowly forward despite some of these early setbacks. And when did you? I mean, what was the fallout? What were the consequences of?
Well, the consequence was because we were a small unit and not a very important department of thoracic surgery, I give confidence to others. And there was many operations like that in France, in Europe, and everywhere. So 1 year later, 100 such transplants were done all over the world. And but they died. All died after maximum 18 months, except 3. One in France, Emmanuel Vitria. He was from Marseille. Marseille is in town in the south of France, and the people used to do jokes. But it was true. It was Emmanuel Vitria who lived 19 years after his transplant. And nobody understood why him and not the other one. So after that, 103 or 100 patients, most of the groups quit. And finally, except Norman Shumway and Chris Barnard, especially Marius Bernard, because Chris did only, I think, 10 transplantations, only 10 transplants, and us in Paris. And that was during the 12 years later, we learned the hard way how to detect, treat the complication, many complications, and the drawbacks of the rudimentary immunosuppressive regimen at that time, and the success were not very important. But year after year, other people want to join us in France also, Daniel Guillemet, in England, Terence English, in the States, Jack Copeland, Michael Hess, and other, Mark Thompson. And finally, in 1980, we founded the International Society of Heart Transplantation. Maybe we were 12 persons to do it anyway, but that was the beginning. Fantastic, yes. And finally, the results were not very good anyway. So a little discouraged, I went to visit Shumway, and he had better result than everybody else, but the treatment seems the same, except on a patient's prescription. I see something I never use, cyclosporine. I said, "What is that, John? Norman?" He said, "Oh, that's a new immunosuppressive agent. You will find it easily. It's done in a drug company near from Paris, Sandoz in Bâle, Switzerland." I come back to France, I ask Sandoz, and I say, "Could I have some cyclosporine?" They said, "No, Dr. Cabrol." Why? Why? Because we're not enough serious. So I called Norman and said, they don't want to give me cyclosporine. Try. But I have to wait for 1 year to have cyclosporine. And that result was wonderful. Immediately, incredibly good.
Managing the immune response was clearly a big issue in the early days before cyclosporin. How were those patients managed? What sort of therapies were you using at that time?
Azathioprine, corticoids, melphalan, anti-lymphocyte serum. Mm-hmm. But we have a lot of problems, many rejection episodes and many other things, yes. So this result was so good that many other groups just resume heart transplant, and finally we try to help them, like Norman helped me, because when I have a problem, I call Norman and say, Norman, this patient has some kind of, all right, that's fine, I will be all right, do that and do that, bye. I said, oh. So we try to do the same for other people in France and Europe, and finally they have excellent results.
So these were, so Dr. Shumway was clearly an important resource for the development all over the world at that time.
Well,
and then his...
Anytime I visit him, he has something new, and I say, oh, but it's not me, or that is Simpson, that is, it's Jameson. I said, curiously, that's never you, but it's always on your department that thing happened. It was a wonderful man. I visited him many times, and he was never operating himself. He helped his first resident. And he said, sometimes said, you know, Chris, I know the operation, I know. And he said, I'm the best first assistant in the world.
But those must have been very difficult days in the late 60s, early 70s, during the time when before cyclosporin was available, and the patients were not doing so well, and eventually many programs stopped doing heart transplants. How were you able to keep your team moving forward with any sense that there was a future in this?
Well, first, two or three things. First, I was encouraged everything by Norman Shumway. I said, that's all right, that's all right. Second, we have Emmanuel Vitriga, who was still living.
Yes.
And he says, you must do it. And in France, some people said, somebody must do it. Because if we don't do, we cannot have any possibility of development and new innovation. So one group must continue.
And were the public, how was the perception of the public in France during those years toward accepting this?
Well, first I asked all the media not to write or to speak about heart transplantation. I say the day when we will have good result, you can go in our operating, everything will be all right. But now nothing, and they were nice. They don't do nothing. Well, I say, during that time I helped more people to die than to live, because they want what they hope they will have a transplant, maybe they can survive. And the family, after the death of the patient, some weeks, some months, some days, some years sometimes, we have patients living 6 or 7 years, they said, anyway, you must continue because we appreciate each morning.
Oh, that's a wonderful thing to say. And how, in those early days of heart transplantation, the idea of donors, of organ donation and brain death were still quite novel as well, weren't they? Were you able, how were you able to find donors, and was this an accepted part of the public?
In France, we were privileged because we have a law as early as 1966, just before the first heart transplantation. The French law was modified to allow the procurement of organs from a brain death donor, first. Second, in France, like I think in other parts of the world, heart transplant looks miraculous for the public. And when we ask after the death of somebody in brain death, we ask the family, and especially when we are speaking about heart transplantation, they said all right. They said all right because they have the impression to participate to a miracle.
Mm-hmm. Yes, so they were enthusiastic about the possibility.
But after cyclosporine, when the result was good, we have a lot of people asking for transplantation. So at that time, and this operation seems now just like another one. So the number of the donor falls down. And we had to do to start a campaign on organ donation at that time. And one of our, in France, one of our Nobel Prize, Professor Jean Dosset, who was an hematologist and discovered the HLA groups, was the president of an association he called France Transplant, to know all the people waiting for a transplant and have some people to wait till we have a call from some intensive care unit and say we have a dead breast patient, as you can. So we have that possibility at that time, and Professor Dosset did a big campaign in France. So we stabilized the number of donors, and we slightly increased, but it's still not perfect. We had about 13,000 patients waiting, and in France we cannot transplant more than 5,000.
So it's still a problem, as
still
in many parts of the world. But it sounds as if the organizational aspects of it were actually very important then, having a central person such as Professor Dosset take an interest in organizing a way to have a donor plan. And
when Professor Dosset retired, he asked me to be the president of France Transplant. So we were very excited to do that, and finally every week we give conference everywhere, and I still continue to do it.
And I'm sure this is what's kept things moving along so well in France.
Yes.
Another area that was very important was the development of heart and lung transplantation, coming from events in the early 80s. Can you tell us a little bit about how this evolved and the role of your team here in Paris?
Well, at that time, the first three heart-lung transplantation were done, one by, I think, Coulet. I think the patient lived a few hours. Then Lillehei did the second one, and the patient, I think, lived a few days. And then Barnard in Cape Town did the third, and the patient maybe lived 1 or 2 weeks. So everybody stopped. And one day I was visiting Norman, and he said, "Chris, go with me there." So he went to the intensive care unit, and I saw a patient there, and he showed me the X-rays, and chest X-rays. He said, "You see, Chris, there is nothing to this patient in this X-rays." So you did it? Yes, I did it yesterday. And so that was the first successful really successful heart-lung transplant. So I was very excited to come back to Paris, and I said to my assistants, hey, we must do it. We must do a heart-lung transplantation. So we have to wait 1 year, and in 1922, I think, because Shumway did that in 1981. 81 is 1981. We did that in 1982, and we have a good result. But at 4 months later, the patient did a cytomegalovirus infection, and finally he died. But we start after that, and we maintain a good rhythm in doing heart-lung transplantation. And of course, we did that because we have cyclosporine.
What were the other big issues that you faced in moving heart-lung transplantation forward?
A pediatric friend of mine someday went to see me in my office and said, why don't you transplant, the heart-lung transplant in cystic fibrosis patient? I said, what is cystic fibrosis? He said, he explained me, and finally I understand this lung was full of of germs and everything like that. You're crazy. The most dangerous things after heart transplantation is infections. So they were lung full of infections. He said, wow, I just read that one of your friends in the States did a heart-lung transplant for cystic fibrosis. Where is it? He said, I don't know. I said, oh, I must be Bartley Griffith. He said, yes, it's Bartley Griffith. So I called Bartley and said, Bartley, what about this cystic fibrosis? He said, yes, I did one case and it's all right. I said, well, but full infections. He said, yes, but we just take everything out. So finally, there is no more infection. You must try it. And we began to do it. At that time, we did heart-lung transplantation and not lung transplantation, because lung transplantation was not working very well. Because we don't implant the bronchial artery, we give the we irrigate the bronchi. So when we transplant heart-lung, there was connection between coronary arteries and bronchial arteries. So that was working well. And finally, that's the reason why we did that. And someday, Bruce Rice did what he called a domino operation. What it is? It takes the heart-lung block in the donor, and I put them in the recipient, but the heart of the recipient was good. So we take this heart and transplant to another people. That was called heart domino operation. So that was a wonderful time. We try everything because we can call each other, and like Terence English said, we used to discuss and speak about our experiences, and finally that was the way to progress.
The early days of the International Society of Heart and Lung Transplantation, as you say, this was a gathering of a very small number of people, but it sounds like it was a real team effort, and that this was really a wonderful group with great camaraderie and interest in helping the field along. That sounds like a wonderful group to have been part of.
Yes, because we are not very numerous to do that. We know very well each other, and our meetings were not so big, and we can exchange our experience, and we like the success of others. We're not jealous, and that was really wonderful to see that each time we have some kind of innovation, we call other people, especially with Shumway also. The group, the Shumway groups was wonderful, wonderful. Stinson, Hoyer, Jamison, Jack Copeland, and all those people were really wonderful. Bruce Rice, everybody. So that was very nice, and it was very encouraging. And I think that explained the success of our things, because the result, even with cyclosporin, was not perfect at the beginning also.
Well, all these little steps then come together, and maybe that's a wonderful legacy for the group of pioneers that really came together in the formation of the ISHLT, this spirit of camaraderie amongst the members in an effort to help the field along by helping each other. Would that be right?
We have personal communication. Mm-hmm. We don't hesitate to call us on the phone and to explain either our problems and our successes also. And yes, it was a really nice day that time. And but finally, some on the way. I remember the last time I saw Chris Barnard. He said, I said, "How are you, Chris?" He said, "I'm on the waiting list." I said, "You want a transplant?" In no waiting list for there. Oh. And 2 months there, he was dead.
Oh, that's...
And Norman also. It was very brief. I think in January, it was not good, and he died in February.
It was a great loss to the community.
Yeah, very great loss. All those men. So I remember my first time in Minneapolis, Minnesota, 1956. Those two guys with the crude cut, the crew cut we call, because we cut our very short. The crew cut. For Shumway, that was all right. But for Chris Barnard, he was ugly with that, really. Yes.
Another area of great importance in the evolution of this field has been the use of mechanical circulatory support. And your team in Paris, again, played a major role in the early days of this therapy. Could you tell us a little bit about what the first cases were like in France and the opportunities and challenges that you faced? I
was not so enthusiastic at the beginning because Norman Shumway said, "Oh, no, that's a very bad thing, So someday I knew he was with Phil Hoyer experimenting electrical ventricular assist device. So I said, well, I will be interested. One day, I was operating a woman, old woman, and she was very sick, and we tried this operation anyway, but she died. And the husband come in my office to thank me. Usually, that in that case, the patient are more grateful. And he said, we did everything for my wife. We did electrical shock. Yes, they had some heart fibrillation. You did an oxygen balloon. You mean an intra-aortic assist pump. And but why did you use artificial heart? I said, because we don't have any artificial heart here. He said, you must have an artificial heart here. So I was, at that time I went to Tucson, Arizona, because Jack Copeland was there. And just the day of my visit, he had a donor, but it was a not very good donor. Finally, the operation went bad. And he asked for an artificial heart. And it did one of the first, what we call bridge to transplantation. That was not working very well, but he said we must have an interest in it, and you must go to Salt Lake City. So I went there and I see Jarvik, and he said you must try, you must have a training. I say, I just for a few days. He said, that's all right. So the next day I operated a calf, and I implant the first Jarvik 7 I ever implanted. And after the operation, he said, oh, Chris, that was wonderful. You did that in 1 hour and a half, and that was fantastic. Last week, Dan Cooley went there, he did that in 3/4 of an hour. I said, all right, all right. And finally, he said, so I can sell you the artificial heart. I say, how much is it? He said, in France, it was 2 million francs. Oh, it's absolutely impossible, excuse me. I cannot afford that. So I went back to Paris, and then the French newspaper, the Figaro, called me and said, we know you're interested in the artificial heart. Could you give us an article? I say, oh, don't speak about that. I have not enough money to buy an artificial heart. He said, well, we can give you enough money. For an article? No, not for an article. No, but we are doing a national subscription. Oh, no. My colleagues said, well, what he's doing? No. He said, no. If we have enough money, we give other artificial heart to other groups. I said, all right. And finally, on the second day of the subscription, I received a phone call from the cabinet of the King of Morocco. And they said, we are buying for you an artificial heart. I said, why? But some years ago, you operate somebody of the family of the King of the Morocco, yes? And we ask no money. I say, no, I'm full-time without any private practice in my hospital. I cannot have any money. Yes, but the king wants to pay his debt, and he offer you the artificial heart.
What an amazing thing.
So I know the power of money. In 15 days, 2 weeks, everything was ready and in place, set up, and we began to use the artificial heart.
And how did it work in the early days?
Well, the first attempt was not a good one. The second one not very good one also, but the third one wonderful. And the day after the operation, I went in the post-operative care unit, and I asked, where is the patient? He said, oh, he's there. I opened the door and see a patient reading a newspaper. I closed the door and said, no, it's not him. He said, yes, sir, go on. And he was with the big apparatus like that, and he was fantastic.
What an amazing moment.
Well, yes, because before this man was like, you're a young man, he was like this.
Yeah.
But I look at the cardiac output, and it was 5 liters, 0.6 or something like that. So, oh, you understand why he's so good.
Yes, and he looks wonderful.
Yeah.
So things have come so far since the 1960s, haven't they?
Well, finally, I think we were a group who used the most the Jarvik 7, yes.
What tremendous excitement there must have been as that continued to improve.
What was most interesting for me was this team, wonderful team. My assistant, Professor Ganjbach, Professor Pavie, and other wonderful people. Nurses, wonderful. Days and night, they were all always ready to do the work. Fantastic. fantastic.
It really speaks to the power of a group of people, and obviously a very effective leader in running the team.
Well, when I stopped operating, the people said, well, we are not, or say no. But my best regret is the team. That was fantastic.
So what do you see next for the big challenges to young surgeons in the field?
Still, I've like Leo said, a lot of room for improvement, he said. And so, I think many things. I remember Lily High. When I went there, my English was not so good, as you can see. And he looked at me and said, Chris, you're going in a dog laboratory. They don't speak English. And when sometimes I tried to speak to him, and he said, fine, Chris, your English is still improving. And finally, I can exchange very few words with him. But when he went to Paris after that, and I invited him to dinner, and he said, usually he said at the end of the evening, he said, Chris, you speak more in 2 years than in 2 hours than 1 year in Minneapolis. Now, find the Lillehei, Shumway, John Kirkland, fantastic also, fantastic. They believe in everything.
Maybe that's the most important thing, is believing in the power of what a challenge to the status quo means, that you have to go out on a limb and push things forward. And
somebody asked me, what do you want for the young men? They don't be afraid to do.
well, that's a wonderful way perhaps to end, and I very much appreciate you coming to speak to us today. Thank you very much.
Excuse me for my very bad English, but...
Oh non, mais non, c'est pas ça, exactement, c'est bon.
I said, you know, Chris, you have a terrible French accent.
It's been a great honor to have you come and
Merci
speak
beaucoup.
to us. Merci à vous. Merci.
Merci.